Hey, good morning, PK. We can see you.
Good morning, Lawrence. How are you? Good
I'm
morning
very-
to the panel.
Very well, sir. How are you?
Good, thanks. We have a really interesting case. We really enjoyed watching Andre work his magic, and hopefully we can illustrate a nice case here as well. So we have on our team today Dr. Karthik Guja, Dr. Vishal Kapoor, Sandeep Singla, and Dr. Sardar Fahan. And we're going to get right into it because it's quite an involved case. So go ahead.
So, yeah. Good morning, everybody.
Slides, please.
Yeah, next slide, please. We have a female patient. She's 67 years old, and she has hypertension, hyperlipidemia, and diabetes. She's an ex-smoker. She has also multiple sclerosis and previous cerebrovascular accidents. So she has bilateral claudication on the right side more than on the left, and the pain on the right side is developing towards pain under minimal physical activity. It was reported as Rutherford class 3, but now she's moving on to class 4. She's on a medical therapy, and her most recent ABIs obtained about 2 weeks ago were right 0.62 and left 0.71.
So Lawrence, I mean, this is a patient who is lifestyle limited. She's got SFA disease. Was attempted in one of our sister hospitals and failed, and I'll show you why. As you can see, so she has very calcified SFA disease just bilaterally. You can see here by the groin shot and the iliac system, she's quite calcified. But interestingly, bilaterally, they fixed her inflow for her claudication initially with a bare metal stent, which was fine, which helped her for a bit, and we had trouble crossing that. But we went up and over using the standard techniques, and we're able to get a catheter down and a sheet down. And then when you take a look at her SFA, so you can see here that she has a heavily calcified SFA. But the problem is she has osteal occlusion of the SFA with no nub, no discernible nub. And I'll show you multiple pictures. So you can see distally she also reconstitutes quite low. Just above the above knee pop. With really, we could have, we thought about doing what Andre did, sticking the occluded SFA and coming up, but we wanted to show something else, just as we had talked with Andre about the preparation of these cases. So you see here that that was an option like Andre did, but this one I don't think you could have stuck below this. The runoff, she has a single vessel runoff to the foot via the dorsalis pedis. The perineal also is there, and it tapers off at the level of the ankle. But she does have a nice posterior communicating artery, which gives rise to, I guess, a sort of a posterior tibial in the foot. So what we decided to do was we decided to try from above, like Brian said in the last case. And what we're doing here is we're looking at the calcium shadows, trying to find whether, probe the nub with a angled catheter and try to find the calcified shadow. The next thing we did was we also went ahead and tried to give some dye and trace down, and that's the collateral right there. It's not really an SFA, and try to find the nub, which we were unsuccessful. So at that stage here, then we tried to probe with a wire. We took a sharp coronary wire, tried to see if it would catch any one of the possible areas of an occlusion, and were not able to do it. So at that stage, we decided to convert to pedal. So we went ahead and put a pedal access catheter. We switched out and we put a micro sheath in, and then we took a shot, gave the usual cocktail, went up with a V18 wire, and then got up to the level of the occluded popliteal, and then started to push. So the V18 was not working at all. It just was not didn't have enough body or didn't have enough strength. So as you can see here, as much as we tried to push, the calcium was not yielding to the small support catheter and the V18. So at this stage, we said to ourselves, okay, let's switch out for an 035 system. So we put an 035 system. We had a very robust, we had ultrasound that showed it was a 4 millimeter dorsalis pedis. So we put an 035 Terumo, Navicross catheter in. And this is not something we standardly do, but in these kind of cases, we felt that there's no other option. Then we went with an 035 wire from below with the support of the Navicross, and we're able to push it all the way up to the ostium. As you can see, the ostium is quite calcified. The problem here to the panel and Lawrence is that you can see that, we don't have a good nub. I mean, so what we decided to do was use external ultrasound. And I'll show you where we are before we go to external ultrasound. That's the loop, and then it was too big, so we switched out to a smaller wire, and then brought it up into the level of the inguinal region, I'll call that. I don't really know exactly where I am. I do now that I have ultrasound. And then we went to multiple views, and looks like the LAO view is the view that lays it out best, and I'll go to that and I'll show you. It looks like we got to this level, and then we switched out to a small wire, and we're basically been ready to try to penetrate this. Now, one of the things that we do here, Lawrence, and I'm sure you do as well as the panel, but for the audience, is really we use external ultrasound at this area to try to see whether we can see the nub. So Dr. Guja is in charge of that today, and he's going to go ahead and talk to you about what he sees, and then we'll go. Go ahead. Oh, actually, you're not mic'd, right? Are you mic'd?
No, here.
Okay, you're mic'd. Go ahead.
So this is a common femoral right here.
No, you have to do it.
Fine. So that's the common femoral right there. And then you can see the calcification, and the nub is just right next to it. It's hard to ascertain from here, but that's the flow you can see. And here you can see the flow. You can see the amount of calcification, especially in the wall, and that's exactly where the nub is. So once we get the wire in, you'll be able to see the wire wiggle and close to the nub, and hopefully we try to connect the dots.
And take off the color so they can see, and then show them whether we can see the catheter. We can see the catheter. So that's the. Huh? What's that?
That's
the
the
ostium.
right
Yeah,
there.
we see that. Yep.
Right
we see
there.
the ostium, the calcified ostium.
We're trying to see if the.
And now
sometimes
we're going to try to find our catheter.
Right
with
there.
The
So that's the
subintimal
catheter.
plane. That's a catheter in the common femoral? Or
It's
the
just right
subintimal?
up.
SFA.
SFA.
Yep. Oh, what we think is the SFA.
Yeah.
So that's where. Okay.
That
that's
you
the
can see the SFA and the.
So catheter is on top of the SFA, trying to now purse. So I want to go back to fluoro here. And Dr. Guja is going to absorb a little radiation for us. What we're going to do is we're going to get a Confianza wire. Guj, why don't you step aside and come back when we need it. So right now, Lawrence and the panel, so we're right here. So we've got the catheter. I'm in the LAO view. I'm just giving a little bit of dye here. So that's kind of where we are. And that's what we thought was the nub, but we have no support to anchor into that, Lawrence. And that's been the trouble we've been having.
Right.
So we're going to go with that 014 wire. And then as I get close, I'm going to have Dr. Guja get back on the ultrasound and tell me whether we're heading in the right plane. Because the problem here, as you guys know, and I'll let you comment on it in a second, is that I could be posterior, I could be anterior, I could be anywhere. So this is kind of where we're at. So any thoughts, anything you guys would have done different? Should I be changing something?
No, I think this is a real challenging case, PK. I think the opportunity for ultrasound to help guide us is really kind of a nice way to think about it. And the challenge is whether it's external or our Japanese colleagues do it with internal IVUS, and they follow the wires internally, is two ways to know whether or not you're in a lumen or towards a lumen. And it actually is a fairly nice way to follow. If you have a good sonographer external, you have to follow the wire over time, but it's a very nice way to confirm where you are and what the direction is. And the challenge here is as you're pointing out, is really, where you reconstitute and where you re-enter, it becomes really critical because it will make or break how this, as much work as you're doing, it's really going to make or break the long-term success here.
Yeah, so I don't know whether I just went with a coronary 014 here. I know there may be vascular surgeons on the panel. This is a Confianza Pro, and I don't know if it's going to have enough penetration. That's posterior wall?
Right.
Okay. How's this? That's much better. You like that better? Okay, sorry. So we're using both.
That's the wire you can see.
You see the wire there? Can you show them the ultrasound, please? And you're going to see we're right at the ostium with the wire. Ultrasound?
Yeah.
Yep.
So you can see the calcification and the wire next to it with the shadow right going down.
We're just still seeing fluoro. Can we see your
Right.
ultrasound?
Yep. Okay. So
Now
go
it's
ahead.
on. Yeah.
Do you see the wire now?
We do.
There's a lot of calcium, so I think I need to get a more penetrable wire, maybe a Connect 250T. Yeah, this is not going to do it, right? No. I need let me get my catheter closer. Let's see. Let's go there. Let me a little more support here. So if I don't cross, is there an option for a re-entry device here? Have you guys done this in this area? We've never done it.
I've done it from a popliteal access because it's 6 French.
Right.
That would be a little bit more challenging. From a pedal access, I know that some of our colleagues in Germany have done it, placing a 6 French tube down there. It just becomes a bit challenging on your principal outflow to put a bigger tube in.
I already have compromised, as you know, with a 4 French, but I'm just trying to see, can I have a little dive from above, guys? So while I'm working on this, rather than watch paint dry here, you like that? You know, we can maybe go to a lecture here and maybe keep me on the side, and if I penetrate, I'll let you guys know. If not, we'll talk about what are the options.
Yeah, no, exactly. Let's work backwards and forwards on both your case and on the talk. So good luck, and we'll have you up on screen as we do our talks as well as the presentation slides.
Yeah, Lawrence, we're really struggling here. We tried all different wires. Now we're in an 035 system. Maybe we're just going to go with a straight 035. We cannot penetrate this. See, look what's happening with my my wire.
Yeah.
So I'm the only other thought we were thinking about, or I was thinking about, is putting a balloon in this area and then doing a facilitated re-entry, piercing out of the common femoral back. But for a claudican, that's kind of overkill in my opinion. I'm already kind of overkilling this, but that's my only question.
Yeah, I think that you're really stuck. I guess one question is the catheter in the SFA currently has a lot of motion. By ultrasound, you're not seeing that is in a large subintimal or subadventitial plane right now. It hasn't gotten any hematoma. Is that?
No, there's definitely no hematoma. She's very comfortable. She's actually having opposite leg pain. There you go.
There you go.
No, I thought I was through too. Okay, give me a little dive. It might be in the vein. Am I in the vein here? Yeah, see, I'm next to it. It doesn't look real.
So
See?
PK, I joined the case late. I was in the wrong place. So, is there any way you can come up from top and try a safari technique, even if you open up the ostium with a balloon?
The problem is, Bhaskar, we don't have a nub.
You're just right there.
We don't have a nub. That's the only issue I'm struggling with. If I had a nub, I can't anchor that catheter, even though I'm using an angled catheter. I can't anchor it.
What
Go ahead.
Other option I was thinking was if you come down from below and anchor from below with a balloon, so you have stability, and then you can penetrate the cap. Because it looks like on ultrasound, you look like you're interluminal, right?
No, we're just behind the posterior wall. So you can see that wire right there and the calcification next to it.
I see that, yeah.
So we just like PK said, we just have to poke into it. The problem is it won't just take that.
Maybe that
So-
Straight
Andre's
stiff.
catheter, that whatever the
Yeah.
poking
Yeah,
catheter
go
would
back
have been.
catheter.
The go back. I was just going to say there's several. There's the cross lock, there's the go back, and even the Houdini catheter. All of these with kind of central luminal obstructive balloons that allow you to go straight. The downside to any of these is that you have to be straight. Right?
Straight gun?
And you have to
Straight
presume that the location is directly in front of you. I wonder if you're close enough to put a balloon down there and then try to do, I still call it the finger of God, and then try to outback that balloon from above. That may be
Yeah,
a
that's
one-shot.
that's one of the things I was just saying, the facilitated reentry. But then then obviously you're going to have a pretty big dissection at this area, and I don't know. I mean, I guess we could try for a few more minutes. We still have a few more, and then I can try to do that, and then the rest is just going to be balloon angioplasty and stent. The whole idea was to show this reentry if we could do it.
So PK, what about using this is Brian Fisher. What about using a guide catheter that has a better angle on it? Because you know where, I mean, the SFA is going to run
I
straight.
think that's your
run straight
target,
every time.
PK.
Got something there, but
That's sort of
a better angle and a stiff wire, like in a Stato or something like that from above.
Oh my God! I got to tell you, Brian, we spent a good portion of our time trying to anchor this. As Brian DiRobertis will tell you, Mahmoud, I called him early in the morning about something with the conference, and I started this case around 7, and we see that no, didn't work. No, don't push. That's the key. So I think the thing is at this stage, it just doesn't want to go. See?
I think you're in the right.
Oh.
I think you're in the right spot
Little
there.
die.
test.
This would be interesting.
Profunda.
No, I wish we were in the profunda. Nice dissection on top of the vessel. Oh, yeah.
The only option I guess you could try if you don't have the,
No,
it may very well be the back end of the wire at this point.
Yeah, really, right? Okay. So let me just try one more thing, and then you guys give another. If you have another lecture, or
Yeah, we got a couple more, so why
Okay.
don't you keep working?
Yep.
And we'll get back with you.
Okay, so we're going to go with an anterior catheter,
Let's flush the sheath.
which is obviously a small balloon reentry catheter from Medtronic. Flush the sheath. And what we're going to do is we're going to go ahead, and this will be our last effort, Lawrence. I personally think, this is a claudicant, like I said. I mean, it's not going to, we're going to try to make her feel better. We don't want to cause any harm to her. At this stage, this
me a
small
woolly wire,
balloon,
please.
if we're able to get in with a reentry device here, would help. We thought we were in multiple times. As we know, all of us interventionalists get hopeful. And, and each time we were in the wrong plane. So, I even tried with a snare because one time I
Okay,
thought
I
we
have
were
the wire.
really, really close.
the wire.
But unfortunately, it didn't work. So let's try the interior, and if not, we're going to call it a day. I mean, it happens, so we'll just call it a day. I don't want to put a 6 French sheath in here and create problems on a claudicant, nor do I want to perf out her common femoral onto a balloon here. That's something we could do if she was CLI or not a surgical candidate or something like that. Then I would think about that. But at this stage, I think judgment is important. I think we've already pushed the limits
second.
quite a bit. And what we'll do is we'll just go ahead. If this works, this works. If it doesn't, we're done.
So at that point, would you then consider a simple bypass for her?
I don't know whether we'll do it because, truthfully, I think what's going to happen is we're probably going to bring her back and try to hit the occluded SFA and see if a different angle is going to help us. I'm not sure if it's the right thing to do. We will definitely talk to our surgical colleagues. I don't necessarily know that they will bypass for claudication. They will definitely for rest pain, but as Dr. Sardar said, we were getting to the level of where we should be, that she was getting close to rest pain. So this might be, a consideration. So now I'm going to go up with this balloon. For those of you who don't know, you have to go up with the balloon to how many atmospheres? 2 atmospheres. And then you have 2 lumens. I don't think that's going to work. Okay. You have 2 lumens through which you can use a catheter, a wire which is quite sharp to try to poke through. Can we go ahead, go up with the...
Roadmap?
No, can we go up with this to 2 atmospheres?
Yes.
So BK, just I've seen this where sometimes what people do is they anchor a balloon in the profunda and in the CFA,
Yeah.
and then they try to poke through the cap and create some kind of channel. So then finally try to find a re-entry from down below.
Close.
We may, like I said, we are going to keep working, and if we get through, we get through. One of the things Vishal and I were thinking about is doing a catheter that's formed. Yeah, go up now. Let's see. Little die. Is that ultrasound-wise, are we good here? Looks like we're good. Yeah, that's the kind of the spot. All right, now give me the torquer. I mean, let's see if we'll get lucky.
So for those of you who have never used this, it's a flat balloon. Looks like it's in the corner it's called a stingray.
Yep.
And it's got 3 ports. It's a distal port where the wire could be over the wire system. It's got a mid port, which will go one way off of the stingray, so medial or lateral, and the other one's the opposite. And what you're trying to do is, in this subintimal plane, you cone yourself against the artery, and what you're trying to do is poke with this sharp tip of this wire, which is an angulated sharp tip. It will find its way into something if you're close. And if you're close enough to enter the true lumen, then you stop,
I think
withdraw,
we're
and then
in.
cross your, yeah, it looks like that's going to be the right spot. And then this thing is a relatively stiff front end, so you want to cross with a balloon and then exchange the wire.
So I think now we're going to go with a snare and try to see if we're in. I mean, it looks like we're in.
Sandeep.
You don't like it? Here, a lot of people don't like it. I don't know why. I mean, I want somebody to like it, you know?
Everybody on the panel loves it.
It looks pretty good right there. I don't know what these
Exactly.
guys are saying.
We like it.
Tell them to open both eyes with the ultrasound.
Okay. No. So you have to put
Okay, I'm going to leave it here. Yep, I'm going to go ahead. So at this stage, Lawrence, what we're going to do is we're going to track an 018 catheter through this. We're going to go down with this balloon, and then we can track an 018 catheter over this, and then switch out for a V18,
Snare,
and then we're going to start balloon angioplasty and stenting this.
Hold on. Can you wiggle the wire?
I can't wiggle the hose now.
Look, there's your wire right there.
Oh, so we are in. All right, so we're in. 100%.
Fantastic job.
Good.
Well, you know, I got to give credit to Dr. Singler here. He suggested the Stingray catheter, which worked beautifully here. So now we're going to walk this out, and then we're going to transfer it for an 018. Hold the sheet, please. 018 what is it called, Trailblazer, and then we'll go ahead and
do a teleport
snare the wire, huh?
You can do a teleport also and just do a stiff.
Yeah, we'll do that, or a teleport. No, this is an 018 wire, right? That's the
no.
problem.
Oh, this is a
014.
Is this 014 or 018, guys?
Should be 014.
Interior is over.
014.
014. Okay, so then we can use
Teleport.
a teleport catheter
Teleport.
from CSI. Have you used that, Lawrence? It's quite good for these kind of little, intimal, subintimal crossings, things like that. I mean, I don't know what you guys have done. We've had a lot of success with that catheter below the knee.
Yeah, I just got one in my hands this past week, so we're going to try them out. The transition is very nice, so we'll see what it looks like in our
Don't have
hands.
it yet.
All right. Okay.
right.
All right. So now I guess I don't know how much time we have, but I'll just tell you what our plan is, because obviously we're gonna finish it now. We're gonna go ahead. We'll do an IVUS just to see what the situation is at the level of the common femoral. Our idea is not to stent obviously the common femoral, and I hope we don't have to. It looks like we entered right at that beak. But what we'll do is we'll go ahead balloon angioplasty from above. We're gonna work from above, and then we'll go ahead and likely put a Supera, which would be our plan without drug because of the heavily calcified nature of the lesion.
So PK, are you going to floss then? Have you already snared and come out and you have single wire control at this point?
We're not snared yet because this is not a very steerable wire, as you know, Brian. And one of the things we're going to do here is we're going to change out to a safer wire, and then we'll go ahead and snare and do our work.
Hey, PK,
Yep.
since we're up to a break right now.
Yeah, you go ahead.
No. What I was going to say is that the next session doesn't start till 10:10, so we can stay with you for a few more minutes. If anybody wants to take their break, they certainly may. The next session will start promptly at 10:10, but we can have at least the opportunity to watch you snare and then get this thing flossed and then begin your work, if that's all right with you.
Oh, it's fine with me. Absolutely. You know that. We're just going to go ahead and work. And you can or if you want, you can just leave us on the screen while everybody goes to the break, and then we'll be working. Not at all.
Yeah, no, that's fantastic. We'll stick with you.
Thanks,
So
Lawrence.
PK, what I was getting at earlier is, are you planning on, you're going to come from below with IVUS, or whichever side you're going from, do you ever put the IVUS catheter on one end of the wire and then work from the top?
Look at this, Lawrence. The catheter is not going.
Yeah, of course. We spoke so highly of it, too.
Oh, man.
What we need to do is.
You know
just
what
put
might work would be the Corsair.
Corsair for
Corsair
sure.
Pro.
Yeah.
Yeah.
So,
Yeah, so we're gonna mother-daughter this. We're gonna go with the Navicross as support, and then this through that. Okay.
So, PK, I don't know if you've tried something called the spiral turnpike or the gold turnpike. It kind of screws in.
It's the angle of the thing.
Yeah, you love that. I know. I know you've used that quite a bit.
I
we,
love it,
We don't
actually.
have that, Bhaskar. We don't have that catheter.
I guess, so the other alternative would be a Corsair Pro,
Yeah.
or a Turnpike like you do for coronary CTOs. And
You have it?
if you really got push
You got a
came to...
Corsair, guys? We have Corsair here, Lawrence, so we'll try that.
Yeah,
Yeah.
Corsair will get through that.
It's a
New
braided
type of-
catheter that'll allow you... Corsair Pro is braided, so it allows you to spin it. And then that's how you get through coronary
Okay, yeah, give him
CTOs.
more this.
The other alternative would be to take a rapid exchange coronary balloon just to create a channel through
Channels,
there.
yeah.
Yeah, let's
Like
do
a
that.
one-
You want
like
to
a
you want to take a rapid exchange? Give me a 2-0 balloon, Habib. 2-0 balloon.
2020.
2020.
220 coronary.
You guys are a lot braver than me because I'm still palpitating to make sure that I'm in. I don't want to balloon the subintimal plane and get in trouble.
You're going through all the emotions of crossing a CTO. There's the elation, and there's the concern. But because if originally you were happy, and now you're saying that you're concerned. So you can't have it both ways, PK.
Lawrence, you know it. It's like you definitely want to be very, very careful with
Yeah.
all this. And that's the part of the reason why, as you know very well, we've done
yeah.
so many cases. Oh, that doesn't look promising. Let's see. I don't know. See, that's why I was a little concerned. Maybe that's why we didn't. Oh, you said you saw it. So let's go with the Corsair. Get the Corsair? Yeah, go open the 2020.
220.
It was definitely in there.
It was in there? Okay.
Unless it in and out.
Vishal says it's in there.
I heard definitely in there.
Yeah, I've heard that
Give us the
too.
Corsair.
Yes. So you have a second set of ears that just heard a very confirmatory statement.
It's funny because I'm one of the old bears. I love my angiographic views. This ultrasound stuff is cool, but I'm never confident unless I see it in an angiogram and feel it with my hands through a catheter.
Right.
So,
Have you done any of this stuff that my Japanese friends are teaching me, which is with IVUS for crossing CTOs? They probe with the wire and they follow it with an IVUS, and that way they see the true lumen surrounding them. I have yet to try this, but
I have never done that. I know that the Volcano team talks about that all the time with their Japanese CTO people. I've never done it, Lawrence. I think that would be something interesting in a case as difficult as this.
yeah, exactly.
So Lawrence, that is something that I do. I use IVUS for every case, every arterial case, and it's something. It works really well. The problem is, especially with if you end up going with an 014 catheter, it just doesn't have the
Flush
same
it the other
pushability.
end,
And they're
guys?
talking about using they're using 035 IVUS when they do that, or okay.
Just you need a wet one.
But,
Flush it.
but you know, they
No,
have
no,
the
you let 'em
patients in
flush the other-
Job.
other
I
end,
mean,
other end.
they'll move 4 millimeters in like 10 minutes, but they'll keep probing it so they actually see that they're luminal. They're
Yes,
not trying to be
You have to take it
subintimal.
out.
No, it's
They're
okay.
remarkably
Don't
good.
take it all the way. Don't. Okay, just
Go.
Okay.
Yeah, it's gripping now.
go now. Go.
So PK, would you consider trapping that wire with a balloon in the CFA so you know it's really true lumen and gives you some anchor to bring your 2O balloon?
You know, I think it's important for, I think you guys know this for sure, but for the audience to know that, you know, what is the condition we're treating here? It's claudication. You know, we're trying to make her feel better. To me, like, if I mess with this CFA too much, and that's part of the reason why I didn't balloon it, is it's not worth it. I need to prove to myself, if I take this catheter into a subintimal plane, that's fine. If I'm in a subintimal plane retrograde, which nothing bad is going to happen. But once I balloon it, you know, then I may get in some sort of trouble. I don't necessarily want to balloon a subintimal plane, but with a small Corsair catheter, it's not really going to hurt me to do that.
No, what I meant was from the
wire and
left
put
up and over sheath, you put a wire into the profunda and you actually balloon the CFA, kind of tampen out the wire against it.
So you're saying tampon on the wire against it?
Yeah, so you basically put a wire into the profunda
Right.
and just, you know, inflate a balloon in the CFA so you kind of trap the wire. Your,
That's- oh, so you trap it and then you try to angle it?
yeah, you trap the wire and then you feed the your balloon into the subintimal space, which
Oh,
you're
I
coming
see
from.
what you're
So it
saying.
gives you a rail. This is just, you know, very similar to your coronary technique.
Right. No, I get it. I think that would be the next step. Let's see whether first we're in. Would you do that now, or would you wait to, because now the Corsair is being loaded.
Yeah, the reason is you don't have much of real estate there to get your Corsair through, so
I'm gonna push
you
this
can give it
wire
a
up.
shot and see.
We have one comment from the
Let's see the wire.
audience. Sir? Let's go ahead and say it, and I'll repeat
Can you
it.
hear me? Okay. Hey, PK, it's Dan Grunstein. How are you?
Hey, Dan.
I'm totally out of my element here, so I may be saying something stupid. But first of all, is the question here whether or not your wire from below is in the target vessel?
Okay. Yes, that is the question.
And I'm going to suggest something maybe similar to Bhaskar. Would it be reasonable to drop a snare, a gooseneck snare from the upper, open it up completely, and if you can snag that wire, you know you got it?
You know, it's funny. We did that before, and the gooseneck snare. That's how we found that we weren't in the right lumen, Dan, with the other wire while the lecture was ongoing.
Gotcha.
So we did try that. There it goes.
Yeah,
so now
you're in.
I may be subintimal or not intimal, but now I'm going to pull this wire out.
That out.
Yep, pull the
Precisely.
wire out. Yep, now we'll find out. And then
So-
I'll feel better, Lawrence.
Yeah.
Let there be blood.
So
Let there be blood.
Yeah, let there be blood.
Actually, you can do an ultrasound. You should be able to see the catheter really
yeah,
good.
we try to do it. There's so much calcification
Oh, is
that
there?
the artifact to the window. So it looks it's intraluminal.
Nope, no blood.
Give us a 5 cc.
Nope, no blood, that's for sure. Well, again, that's part of the, give me another wire here. Give me a hydrophilic, a Spartacore.
No, a fielder. Regular fielder.
Definitely no blood. I think we were subintimal all along, guys.
That's really surprising. It looked like it's truly following the right plane.
Yeah, well, but that's where I think angiograms are lies sometimes.
Agreed. But what PK is showing, and it's really it's something that's actually what we always
Shaping.
try to teach, is you got to be confirmatory with what you do, and the first do no harm rule is critical. And for a claudicant to really push on this becomes less beneficial for the patient. So I got to commend you, PK. That's pretty cool.
Thank you very much, Lawrence. And I think, like I said, so I think we are going to stop. If this is not in the true lumen, I may probe a little bit offline. If I get in, I get in. If not, you know what? So we call it a day, and she'll be fine. We're going to have to treat her or send her to our surgeons and offer alternate therapies, which also work very well.
Agreed. Just see if you got a wire in there, and then
Yep.
we're going to come up on a hard endpoint. I think
Sure.
if Mike Baccarat's around, he's going to take over the next moderating.
Yeah. Yep, we're definitely not in the lumen. Oh,
There you
Yep,
go.
we're in the lumen.
That looks.
That's the lumen, that's for sure. Yeah, I can tell you this is the lumen. See how it's vibrating the wire?
Yeah,
So we are in the
So-
lumen. Yep.
yeah. So let's
now
see if we have some blood.
Exactly. If not, then we're not going to be happy
We
again.
work in blood, so
Yes, sir. Blood is coming
Yeah,
through.
there we go.
God bless you.
All right. All right. So
Well
we'll just
done.
balloon.
Good one, PK.
I'm sorry, guys. It took me the whole hour to cross, but we'll take care of this now. Thank you.
Yeah, you picked a real easy case for this session. Thank you.
Take care.
All right, so thank you, PK.
We went ahead, we snared it, we externalized it, we safaried it, and so once we safaried the wire, now what we're doing is we're just going to go ahead, and now this is the 018 Trailblazer going intraluminal from above, and then what we're going to do is that's it, that's enough, and then what we're going to do is pull out the wire from below, and then we'll be done. Actually, I'm actually going to take this Trailblazer further down so I don't shear the wire, but I shouldn't be able to shear it.
No, we have the
So
sheet
either
now.
way, we're going to go ahead and take this out, and now we're going to work from above, and we'll come back to you and tell you how we're doing. Well, how are you, Mike? And welcome to the panel. And want to give a little update to the other case. We we finished ballooning the other case totally, and now we're in the process of deploying some Superas. And I'll show that to the audience in the afternoon when our colleagues get done. Okay, Mike, how are you? Can you guys hear me?
Yep, we
Yes.
can hear you.
All right, great. I just wanted to show what happened this morning and finish that case because I know that, like Andre, we crossed as time was running out. So if for those of you who were there, it was a long segment occluded SFA that we got distal access and came back up, as you see the wire coming here. But I just want to cut to the chase and save time. We used ultrasound guidance to identify the common femoral and the osteal SFA, which was totally flush occluded. Then we were able to cross using the anterior catheter, and then what we did was we this is where I showed Mike. We externalized the wire with the use of a snare. After we used the snare here, we did an intravascular ultrasound, and we were 100% dissected all the way down. And I want to show you what we did. So we wanted to keep it really simple. We did multiple balloon angioplasties with a Dorado balloon because of the level of calcium, as you can see. And then we went ahead and put a Supera stent. And I want to show you here, this is the ostium just after ballooning. There was significant amount of recoil and also dissection in the proximal. And then we went ahead, put a Supera stent, post-dilated some of those Superas. And I just want to show you the final result because it was quite remarkable, and we were able to do this, which is great. That because we were on the verge of giving up on this case. You can see here the SFA, a little bit of a dent there, but we could not expand it, even though we went to very, very high pressure before putting a Supera. And then in this area, in the ostium, we had to go ahead and put a Zilver. Now it looks like it's pinched because it's a posterior takeoff of the SFA. So we went to another view, and you can see in this view, the Zilver PTX is very well expanded in the front. So, it was a cool case and just wanted to show you the nice result and how well Superas can perform in this. So without further ado, we're going to go and show the case presentation and start our live case.